Go ahead.
Okay, good afternoon, everyone. My name is Lindsay. Together with JP and Ross, we will be presenting on HIV opportunistic infections and prophylaxis. So firstly, we'll be starting with opportunistic infections. So a basic definition, an opportunistic infection is basically an infection that occurs more frequently and more severely in immunocompromised individuals. We'll go into some examples of some HIV-associated infections further into the presentation. With regards to prophylaxis, there can be types of prophylaxis. You can get a primary prophylaxis, which is basically therapy to prevent the onset of the disease, versus a secondary prophylaxis, also known as maintenance therapy, to prevent the relapse of a treated disease. With regards to HIV prophylaxis, in the primary healthcare EML, basically goes through 3 different medications used to prevent infections, which we'll go into further detail in the presentation. Okay, so on the next slide. Next slide, please. Here are some examples of some HIV-associated opportunistic infections. In terms of respiratory infections, you can have a pneumonia, whether bacterial or PCP, even toxoplasmosis or TB or MAC, which is Mycobacterium avian complex. Some neurological infections could be cryptococcal meningitis. Oncological diseases, although perhaps not quite an infection, but definitely associated with HIV, include lymphomas, Kaposi sarcoma, cervical cancer. Gastrointestinal infections can include aphthous ulcers, candidiasis, necrotizing ulcerative gingivitis, HIV-associated diarrhea. Dermatological infections could be herpes simplex, herpes zoster, a papular pruritic eruption, seborrheic eczema, as well as fungal infections. Okay, so moving on to the next slide. We'll firstly be talking about isoniazid prophylaxis, also known as IPT, isoniazid preventive therapy, which basically prevents TB. It's indicated for any HIV patient at any CD4 count. Contraindications to this is basically active TB. So you would exclude TB, you would ask the patient if they have any cough, fever, night sweats, or weight loss. And once TB has been excluded, then you would start IPT with the ARVs. So basically it would be isoniazid 300 milligrams daily for 12 months, also with pyridoxine 25 milligrams. Some adverse effects to look out for include hepatotoxicity. So patients would complain of nausea, vomiting, jaundice, brown urine, or right upper quadrant abdominal pain. Okay, now moving on to the next prophylaxis, which is cotrimoxazole, which prevents PCP or bacterial pneumonia, as well as toxoplasmosis or isosporiasis. Indicated for any patient with a CD4 count less than 200, as well as if they are HIV stage 2, 3, or 4. So the dose, it would be cotrimoxazole 160, 800 milligrams daily until the CD4 count is more than 200 for at least 6 months. Adverse effects to look out for include hypersensitivity, so a maculopapular rash. Okay, moving on to the third prophylaxis, we're going to be talking about fluconazole, which prevents cryptococcosis, especially cryptococcal meningitis. Indicated for any patient with a CD4 count less than 100, and if their cryptococcal antigen test has come back as positive. So the lab automatically does do a serum cryptococcal antigen test, a CRAG test, for any CD4 count less than 100. So if the serum CRAG test comes back as negative, you would start the patient on ART. However, if the serum CRAG has come back as positive, the patient would need to have an LP in order to exclude a cryptococcal meningitis. Okay, next slide. So if in the LP, the CSF has come back as CRAG negative and the patient has no meningitis symptoms, So you'd start the patient on fluconazole, 1,200 milligrams daily for 2 weeks. After these 2 weeks, then you would start the patient on an ART, and then decrease the fluconazole dose to 800 milligrams for 2 months. Following the 2 months, then you would decrease the dose once again to 200 milligrams daily for a year, or until the CD4 count is more than 200. If in your LP that the CSF came back as Crag positive, the patient basically has cryptococcal meningitis, in which you would then have to refer the patient to a higher level of care. And at the hospital, then they would have to start the patient on amphotericin B, as well as fluconazole for 2 weeks. Following which, after these 2 weeks, then the fluconazole can be decreased to 800 milligrams daily for 2 months. And then you would consider starting the ART after 4 to 6 weeks of having started this antifungal treatment. And then the patient can be down referred to more of a primary healthcare level, in which then the fluconazole will be continued at 200 milligrams daily for 1 year, or again until the CD4 count is more than 200.
All right, good afternoon. Could we go to the next slide, please? I'll be dealing today with the issue of PrEP, or pre-exposure prophylaxis. And PrEP is defined as the use of antiretrovirals by HIV-negative individuals before they are exposed to HIV in order to minimize the risk of them acquiring HIV. Next slide, please. An important thing to be aware of is when PrEP is indicated. And as outlined on the slides, this would be in patients who are firstly HIV negative and in whom you have no suspicion of acute HIV infection. And in patients who are suspicious of acute HIV infection, you should defer the initiation of PrEP for 4 weeks and repeat the HIV test before initiating them. Other patients in whom this is indicated would include patients who are at substantial risk of HIV infection, patients who are willing and able to adhere to the regimen, patients who are prepared to undergo 3 monthly monitoring, which I'll describe in a short while, and patients who have no contraindication to any of the agents which are to be used. Next slide, please. These contraindications that have been mentioned would include patients who are HIV positive, patients who have a GFR of less than 60, and in this situation, patients should be advised to stop taking PrEP and then repeat the test in 2 weeks, and if it's normal, they can be reinitiated on PrEP. Patients who are using nephrotoxic agents, as well as young individuals with a weight of less than 35 kgs, or who are under the age of 15 with a Tanner stage of less than 4, should not be started on PrEP. And the final contraindication is patients who are unwilling to or unable to adhere to the PrEP regimen. Next slide, please. In patients who fulfill the criteria to be initiated on PrEP, all of these patients should be investigated as follows. They should all undergo VCT, and routine bloods would include creatinine clearance, hepatitis B surface antigen, and an RPR. Patients should also be encouraged to have a hepatitis B vaccination. In patients who are hepatitis B surface antigen positive, an ALT should be performed prior to initiation, and if it's elevated more than 2 times the upper limit of normal, they should be referred to an infectious diseases specialist. It's important to note here that hepatitis B surface antigen positive patients are not contraindicated to PrEP, but it's just that we need to monitor the ALT. Patients should also undergo a pregnancy test, and again, pregnancy is not a contraindication. Pregnant patients should actually be encouraged to be on PrEP. It's just something to look out for. Finally, patients should undergo syndromic STI screening. Next slide, please. So in terms of the initiation of PrEP, the first regimen the regimen that they would be started on is a 1-month supply of tenofovir 300 milligrams per os daily and emtricitabine 200 milligrams per os daily. At this stage, patients should be counseled on HIV prevention, STI prevention, and pregnancy risk associated with unsafe sex. And it's also important to note that these patients are at a higher risk of intimate partner violence, and so this should be discussed with them as well, and they should be screened for this. Patients should also be offered condoms at this stage, and in terms of advice to give to patients, adequate levels of the drug should be reached within 20 days. Next slide, please. In terms of ongoing treatment, at the first visit after initiation, patients should undergo a repeat HIV test and another STI screen and undergo counseling as outlined above. Patients should thereafter be reviewed 3 monthly. Creatinine clearance should only be repeated at month 7 and annually thereafter, provided it was normal. At each visit, the patient should be monitored for side effects, And here the major side effects would include renal toxicity and decreased bone mineral density, as well as hepatic steatosis or steatohepatitis. Here, the first two of these are generally reversible on cessation of the regimen. Minor side effects, which 1 in 10 individuals can expect to experience, would include GI symptoms and weight loss, but these tend to be self-limiting. In terms of discontinuation, patients should only be stopped on their PrEP regimen 28 days after the last potential exposure. And patients who are infected with a hepatitis B may have a flare on discontinuation, and so one should consider referral to an infectious diseases specialist for this discontinuation.
Next slide, please. So I'll be speaking about post-exposure prophylaxis. So the Health Professions Council of South Africa does give us some guidelines on how post-exposure prophylaxis should work, particularly from a healthcare worker point of view. They recommend universal precautions be taken, things like gloving, wearing eye protection as appropriate, discarding sharps appropriately, etc. They recommend that education programs should be provided by employers so that healthcare workers are advised on possible sources of risk like needle sticks and not recapping your needles, things like that. And they recommend that the employer should have a protocol in place for what a healthcare worker should do should they get exposed to infectious fluids, and where they are supposed to get their post-exposure medication from, and whose responsibility is to pay them, will they be refunded, etc. They also recommend that insurance should be made available to staff, whether that's provided by the facility they work at, or if it's done in a private capacity. And they specifically mention medical students who are at high risk of needle sticks due to inexperience and eagerness to join in procedures which they may not be familiar with. Next slide, please, Prof. Testing for HIV. Well, if you're going to consider taking post-exposure prophylaxis, you need to know if the patient is actually positive or negative. If the patient is positive, that's obvious. If they're negative, you need to bear in mind that they may be within the window period, and you should ask the patient about things in which case they could still be positive during that window period. If the patient is unknown for HIV, then there can be a bit of an issue, because if they're unknown and they allow you to test, and you find obviously they're positive or negative, but if you want to test them and they refuse to test, the HPCSA does say that even if a patient refuses, you may use an existing blood sample and test without the patient's permission, provided you inform the patient that this is what you have done, and that you will not reveal the result to them as they've requested you not to do so. It does not state that you may take blood from the patient in order to test them against their will. So that presumably would be abuse, and so you're not allowed to take blood with the express intention of testing them against their will, but you may use an existing sample. If we could please go to the next slide. So documentation is very important, because if you, for example, have insurance that will protect you should you seroconvert and get HIV, you need to make sure that you followed all the legal steps and requirements as part of that contract, so that you don't miss out on whatever disease benefit that is. So that would be documenting exactly what happened, what steps you took. Was the patient positive, negative, or unknown? Did you take your ARVs? Did you follow up? Did you do your follow-up tests? If we could please go to the next slide. So there's different kinds of exposure. You can get exposed to infectious fluid from an HIV positive person, an HIV negative person, or a person who doesn't know. If they're unknown, you should generally err on the side of caution and consider them positive. Exposures may be broken down into, as per the EML, the National Department of Health guidelines, they divide it into occupational and non-occupational exposures. And under non-occupational, it's further divided into inadvertent and sexual assault. If we could please move on to the next slide. So occupational, I mean, we're all familiar with the needle sticks and sharp injuries, scalpel blades, etc. The risk of transmitting HIV, if you're on PEP, is about 0.23 to 0.3% from a percutaneous puncture. Obviously, this depends on the actual viral load of the patient, if they're suppressed versus very high viral load. Contact with skin and mucous membranes, that is about 0.9% risk of transmission for HIV. And you should consider all fluids as hazardous, even though tears, saliva, stool, and urine, if they're not visibly bloodstained, they do not represent a significant exposure. But you've got to bear in mind, if, for example, a patient was in an MVA, you could expect hematuria. If the patient had colorectal cancer, you could expect blood in the stool. So you should never totally rule these things out, and you should always use universal precautions. Remember, of course, that doctors are not the only people that get exposed. It can be dentists, nurses, physiotherapists, paramedics, auxiliary staff such as cleaners, and people often forget that that cleaners are also at very high risk of these things if you leave needles in the beds and in the sheets and things. Non-occupational, some people have of the idea that post-exposure prophylaxis is only for healthcare workers and people that have been sexually assaulted. That's not true. People who have engaged in consensual intercourse and found out later that the source person may be positive. People can get sharps injuries, whether that's IV drug users or children that might get pricked on a needle or whatever it may be. People can transmit HIV through breast milk, and there are stories where a mother may leave their children in the care of a family member, and that family member decides to wet nurse the child for whatever reason, and then they can expose the child to HIV. And it's somewhat contrived, but it is possible, and it is in the guidelines of transmission through breast milk in a hospital, where mothers will give breast milk to leave in the neonates facility to give to their child, and it is possible that they can be mixed up, although it is quite unlikely. First aid, people who render first aid are also at risk of HIV. Contact sports like rugby, human bites, and pre-mastication of food. That's where people may chew the food for their children, particularly if they're teething or if they have sores in their mouth. If we could please move to the next slide. So you should do some baseline investigations, because if you start someone on antiretrovirals, on post-exposure prophylaxis, you can precipitate adverse events, and these are on the order of about 1 in 1,000. So they're uncommon, but they do happen, and they can be very severe. And unlike some medications, these typically occur very early on. So it's important to identify any underlying issues before you give someone post-exposure prophylaxis. So obviously you should do a full blood count, U&E, hepatitis B, surface antigen, and antibody. Bearing in mind that the risk of transmission of hepatitis B, it's about 30 to 40%, depending on the viral load percutaneously. So you essentially, by that statistic, you have about 100 times higher chance of getting hepatitis B rather than HIV from a needle stick. You should also do hepatitis C antibody, RPR for syphilis, and your HIV Rapid Plus analyzer. And as I say, it's very important to document all of this, particularly for insurance point of view, if you want to get the person paid out, or if it's yourself. If we could please move on to the next slide. So which agents? Well, you must give them preferably in the first 2 hours. After 2 hours, the efficacy of these agents does decline up to 72 hours maximum. After that period, they are found not really to work. And you should use 3 agents for 1 month. And the National Department of Health does recommend TLD, tenofovir, lamivudine, and dolutegravir, and except in some exceptions, which I'll get to. There are other regimes, but this is the one, bearing in mind that we are the primary care facilities. This is within our scope. There are other ones, but not necessarily recommended by the Department of Health. Next slide, please. So there are some exceptions, and here with pregnant women less than 6 weeks, I'm aware that dolutegravir has been found to be safe at all stages through pregnancy. That was a recent directive. However, it doesn't specifically state for a post-exposure prophylaxis point of view. It says that for treating HIV. So I've left this in for now, that pregnant women should take this adjusted regime, swapping out dolutegravir for either atazanavir, ritonavir, or for Eluvia. But bear in mind that this will very likely change in the near future. If the source patient is already known to be failing tenofovir-based regime, you're obviously not going to give them as post-exposure prophylaxis something containing tenofovir. So you instead give them zidovudine and lamivudine BD. For neonates, I would honestly recommend consulting an infectious diseases specialist, because not only are there special indications for each agent, the actual monitoring of response to these agents, whether it be through side effects or renal and hepatic function, that you would need a specialist to be able to interpret. Children, they use a regime of zidovudine, lamivudine, and lopinavir, ritonavir, and these are adjusted by weight. If we could please go to the next slide. So monitoring, you have to monitor the patient's UNE if they're on tenofovir, because they can get acute renal failure, and a full blood count if they happen to be on zidovudine, because you can get anemia and agranulocytopenia, cytosis. At 6 weeks, you should repeat an ELISA, and at 4 months, you should repeat an ELISA. Obviously, if the person tests positive at any stage, you would then consider them positive and do appropriate workup. And I've said see national guidelines, hepatitis B, C, syphilis, etc., because that depends on what your initial screening was. If we could move on to the next slide, and that's all.
Hi, everyone. Thanks to the group. Any comments from anybody? I think there were some questions, and somebody had their hands up. I'm not sure that was the case. JP, is that for you to present?
No, Prof.
You have a question.
JP, Ross, and Lindsay have just presented now.
Okay.
So we can lower our hand.
That's fine. All right. Thank you. Any other comments? Any questions from anybody? I know there was an add-on. Anna Jacobs talked about drug-sensitive TB. Anna, do you want to just explain that briefly?
Hi, Prof. I was just going back to the guidelines. I think they're the 2019 guidelines.
Yes.
And there's different guidelines. So for TB, there's drug-sensitive versus non-drug sensitive. And then there's the site. So if it's neurological versus non-neurological, and then the CD4 count also plays a role. Right. So I think someone actually shared the guidelines in our WhatsApp group.
Not a problem. Great. Thank you. Right. So I think, the guidelines are extensive. Thank you for sharing this and being succinct and pointing out things that probably are useful. I don't know if people feel at all any confusion, anything that they'd like to raise. Dr. Petkova, Dr. Kabir, anybody, Shane, Dr. Murphy, anyone else to comment?
I'm okay, Prof.
All right. All right. Well, thanks a lot. Let's stop there for the